we're really excited to share with you all today. But before that, why don't we get started with introductions. So this is Alicia from OPCA, and can I have folks that are joining via the webinar and on the phone introduce themselves?
Hi, this is Linda at Rogue Community Health.
Hi,
Good morning, this is Rick Rankin with Rogue Community Health.
Hi, Rick.
Hello.
My name is Treva. I'm from Richmond, OHSU.
Good morning.
Hey, this is Brian Frank, also from Richmond.
Hi, Brian.
Hi, Brian.
Hi.
It's Ned Mossman and
Mary Mittendorf
at OCHIN.
Hi, guys.
Good morning, it's Maria from the Wallace Medical Concerns.
Good morning, Maria. All right, so why don't we then go ahead and get started. So as I mentioned, we have two presentations today. The first one, hold on, how do I, sorry, we're dealing with some technical stuff. Give us one moment. Okay, there we go. So as you all know, this is our second webinar as part of the Food Insecurity Learning Collaborative. And I'm really excited that today we're going to get a chance to hear from two different organizations. First, we'll be getting a presentation, a live demo / walkthrough from OCHIN, who's going to share really where and how food insecurity data is collected and tracked within OCHIN-EPIC, within the EHR. We're also going to hear from an organization called Crossing Healthcare that is located in Illinois, and they're going to share their approach to food insecurity screening and intervention, and how they've built up some really interesting work to address food insecurity needs in their community. So we're going to be moving pretty quickly here, short on time, so I'll go ahead and jump in at this point and pass it over to Ned and Mary at OCHIN, who are going to get us started for the first 20 to 25 minutes with a demo. And I'll mention from the get-go that why don't we let them do their demo first, and then after they present, we'll have an opportunity for folks to ask questions and seek clarification on anything that might be confusing. So we'll start with a presentation from them, and then we'll open it up to more of a dialogue and back and forth as we get going. So with that, I'm going to now, and actually it looks like we have some additional folks that have now joined. So anyone that didn't already introduce themselves, can I have you go ahead and introduce yourself?
So this is Katie, and I'm here with Terry, and we're from Reinhardt.
Hi, Katie. Hi, Terry.
Hello.
Okay, so with that, I will now pass it over to Ned. And Ned, bear with me. I'm going to do actually. So just to clarify, Ned, would you like me to pass it to you or to Mary for the demo?
Yeah, you can pass it to Mary. Thanks.
Okay, got it. All right.
All right. Thank you very much, Alicia. And so just by way of a little bit of quick background, many of you probably have seen that we have in OCHIN-EPIC, we have the social determinants of health tools in there. There's a summary. There are flow sheets to collect information. The 30-second history is that we worked with the National Association of Community Health Centers and OPCA and Alicia on implementing what was called the PREPARE tools, and that was a set of social determinants of health tools that was an effort to get a sort of standardized nationally available set of tools into different EHRs. And then we had the chance to sort of build off of those tools, and again worked with Alicia and others in our clinical operations review committees to add other questions or add some granularity to the questions that we already had. Among those, the food insecurity questions, we, and I'm sure you'll hear more about this from Alicia, or probably already have, we went with the FDA recommended 2 questions on food insecurity, and Mary Middendorf is going to demo our EPIC tools and sort of focus on where the food insecurity topic lives in both the data collection and display portions of EPIC. And with that, I'll go ahead and just turn it right over to Mary.
Okay, so I'm going to start here with, this is our entire 3-page paper questionnaire for the social determinants of health, and this is available on the OCHIN Site Specialist Wiki as part of the June enhancement package this past summer. So I'm just going to scroll down to the food questions, and these are from the USDA. So 2 questions about worried about running out of food, the food didn't last, and then one about can't afford to eat balanced meals. So these are the 3 food questions. And now I'm going to show you, I'm going to jump over here to EPIC and show you how they can be recorded in EPIC. So the first way would be going to reporting workbench and running a report on patients with upcoming appointments, say patients with appointments in the next calendar month, and then sorting this by patients who have an active MyChart, so patient portal status of active, and then could select any patients who haven't had their questionnaire done in a while. So this is the answer to the last meal balance question, and this is how many positive responses the patient had on the food insecurity questions in this column. So I see that this patient actually didn't complete it, so I'm going to go ahead and send it to Eliza again using the drop down and say send patient messages. This sends, you can actually put many patients at once and send them MyChart messages. Add questionnaire, I'll send the SDH questionnaire, and I can put in a subject, please fill this in. This will help us learn about you. And then Eliza will get an email telling her to go check her MyChart account. And when she logs into MyChart, that message will be waiting there. Read your messages with the questionnaire waiting to be completed. And it will have all these domains, including these 3 housing questions. Now, it's pretty usual that patients either don't have MyChart or don't fill out their questionnaires ahead of time. So if she hasn't done it, I see when she checks in, this is in the appointment desk, there are columns that I can pull in. These bring in the last SDH food, positive responses, so, and the last date. So I see that hers is incomplete for food. And while I'm checking her in, I can go ahead and ask those questions, give her the paper questionnaire, and then transcribe them back in, or verbally ask her the questions as I've got the screen up to record answers. So here from that SDH button at the top of the toolbar, I can see all these same questions and right here it calculates for me how many were positive. Anything, if any one of them is positive that is flagged as abnormal, is something that's appropriate to follow up on. There's also a decline button available when it's end user facing. We don't show the patient the declined button, either on the paper form or the MyChart form. I don't really want to continue this check-in. And then I'm going to show you how this shows in the exam room. So here in the exam room, it can be filled out in the exam room as part of the screening section of the rooming navigator. You can fill out social determinants of health or a number of other screenings, and all these questions, including the food, will be brought in. Now, you don't need, in any of these places, except I guess MyChart, you don't need to ask every single question. If there's only certain domains, if you only want to do food at your clinic, that can be the decision that you make and only fill out that section. So the MA might do this while rooming the patient, either, again, asking the patient the questions or using that paper questionnaire. And then the provider view, I'm going to not fill this in because I actually did it during registration on this patient. In the provider view, we'll see all the latest responses from this patient on the questions. So down here under food, we've got these responses, and it pulls in separately, actually, the ones from MyChart and the ones entered in flow sheets. And up at the top, we'll see here, this patient actually has a lack of food associated with ICD codes that's been entered on the problem list. So the provider or someone else who you grant security and by policy permission to do this can go into the problem list after the questionnaire has identified the patient's food need and actually put in a problem list entry. There are ICD codes for lack of food and other social determinants of health available now. So you can put it on the problem list so it stays with the patient wherever they go. And we can put in an overview note to talk more about what the patient's situation is. And so once that's been updated in the future, the overview note will show here in this summary, along with, of course, still the latest questions. Now, I might want to send the patient to a food pantry or send them to a social worker who can help them set them up with food stamps or something like that. So some of our service areas have built out preference lists of local organizations that they can refer patients to, or just built out referrals to refer internally to their own staff to help follow up with the patient on their social needs. So I'm going to show you an example of that. We have community referrals. So my top set is housing. So here we've got under nutrition a bunch of Portland area food banks and farmers markets that accept food stamps and so forth. So we can select a few of these that are appropriate after talking to the patient to what their situation is and where they live. I just have to click through and say, yes, I do want to order multiple of these. Within the preference list, and this is maintained by the site specialist, it will show in the scheduling instructions whatever additional information the patient may need to bring with them, hours of operation they often include, and then each actual resource is built out by the OCHIN help desk on request, so we'd have to get the information from you guys so that we can keep track of what organizations are being referred to, how often, so we get the name, address, phone number of each one. Here we are. We've got hours of operation. So I could go ahead and sign these. I have to put in a provider in my service area. And then I can make sure that the patient gets this information about those referrals on their problem list, go into the patient instructions and type .pt referrals, and this will pull in that information that the patient needs about these organizations. So where they were referred to, the address, if there was a phone number on file, and then the instructions maintained by the site specialist that tells them what they need to know. And then finally, over time, now that those referrals are in the system, they're actually going to show in this summary as well. So down here below the latest answers, we have the referrals that were placed on the patient to these resources. And then at a future visit, the MA or the provider, anybody who, if you choose to give them security to the referral module, would be able to hop in and actually edit those referrals and indicate whether the patient got the services they needed or not. And finally, you can see how this data is changing over time by going to the synopsis. And you'll have to select the social determinants down here. And this will just show, just like anything else in synopsis, it'll show the values over time. So that's it. Are there any questions?
Hi, everybody. Thanks. So that was really helpful, and it sounds like at this point we can open it up to questions. Thank you, Mary. I do want to start us off by saying that we have one question that was typed in from the folks at Reinhardt, it looks like, and they're wondering if you can see the comments that were typed in while answering the questions in EPIC.
I don't remember. Let's see. Let's see. Financial resource drain. Somewhat hard.
Mary, are you still there?
I'm not hearing anything. This is Rick at Rogue Community Health.
Yeah, thanks. Yeah, we're not as well. Mary or Ned, can you guys hear us?
While we're waiting for them to return, can we invite you to, all of you, to add your questions in through the comment feature or the chat feature, because we're not sure that they'll hear us.
Okay, well, sorry about that. We seem to have lost the phone piece from Mary. I don't know if she accidentally signed off or what happened here. But anyway, so I guess with that, as Victoria mentioned, so please do send questions into your chat box. or into the chat box, and we will hopefully can get back to those if we're not able to get them answered right now. And Mary, is that you? Okay. All right. Sorry about that, guys. Yeah, it looks like OCHIN lost their audio. Okay, so can I ask other folks to just confirm that you can still hear me? I just want to make sure this isn't a larger issue.
Yep.
Okay, great, thank you. All right, so with that, I guess, why don't we switch gears a little bit and go to our second presenters. And like I said, maybe we can come back to the OCHIN demo at the end if time allows. But I do want to make sure that we now give time to our second presenter, Allison, who's going to be sharing about her organization, Crossing Healthcare's work on food insecurity. So Allison, are you on, and can you hear me?
Yes, I can hear you guys. Can you hear me?
Yes, we can. Welcome and thanks.
Well,
I don't think yeah, thanks for joining us. So Allison, I have your presentation, and I think we agreed that I'm just going to pull that up and move us through the Prezi presentation that you put together. Is that so? Should we get started with that?
Yeah, let's go ahead and get started.
All right. So why don't you just let me know as you want us to advance the slides.
Okay, yeah, I'll let you know when to advance. So while you're pulling it up, I'll just kind of give everyone a slight introduction to possibly why I'm on the phone call. I think it's very important looking at your EPIC system, as the last presenter was going through, that you guys have screening tools for social determinants of health, and I'm so interested in that. I think that's fascinating. And possibly my presentation will have a slightly different spin on things, but attacking food insecurity in our community from a different setting. And so that people know, I am a registered dietitian, and I started working with Crossing Healthcare almost about 3 years ago. And very quickly, we went from, in the last 3 years, about 9,000 patients to 17,000 patients. And in the very beginning, food insecurity was something that was at the forefront of all of my patients. Because the unique thing about them is I get to spend an hour with them, so I really get to learn our patients and be able to make those connections very quickly where providers or other providers aren't able to because of time parameters that are set on their visits with the patients. And so it really got me to thinking different, hence this slide. So if you could just hit it again. I know it's got, there we go. So nutrition education and healthy food is a very primary, low-cost, effective way to provide excellent health care. Knowing that, it's looking at prevention. And so thinking out of the box or looking at the solutions differently than maybe traditional health care is going to be such an important role in our future. And then also figuring out the return on investment with those things. And people in general are visual learners. And so what I find is that generationally, everyone cooks and eats how they were raised or brought up to cook and eat. And so in order to be able to open their mindset to healthier food choices, you have to visually show people how to do that. And then the connections start firing, and they see how easy it is, and they get to taste it. So knowing all of this, we are a firm believer in changing our environment so that the healthy choice is the easy choice. So often the unhealthy choice is the easy choice for our clients and ourselves. We do know this. And so how do we look at our current environment to change that so that the healthy choice is easier? And we can do that in so many ways. Before we move on to the next slide, I think it's important that in my process of being here, sitting down and giving someone a sheet of paper to say this is your diet and this is how you should eat is not satisfactory. So I feel as if centers across this nation, if they have dietitians that are doing that with their clients, then we need to have these conversations because that's not good enough. We've got to figure out what our patients' challenges are and then help them find real solutions for what's going on with them. We've put in place many health and wellness or nutrition-related programs that really break those barriers for our patients and improve their overall health through lifestyle changes. And so I reached out to our local food pantries initially because my patients are their clients. It's very clear. I go over and I work with them once a month at the different food pantries, and my patients walk in the door, so I know them. I also reached out to our local soup kitchen, which is doing some innovative things in clean eating and fresh foods, and they have a program called Mercy Gardens, which is a soft skills-based training program to teach people how to garden, and we wanted to support their efforts. And then we also became an agency of our Central Illinois Food Bank, so the large food bank in our area, so that we could be an agency partner. And we're working with the food bank to offer healthier choices at the food pantries at the lower level. So there's a lot of underlying work that's going on with food insecurity in our community. But if you want to change to the different slide, the next slide. So here's what we know. And we know that, and some of these statistics came from our population, and some of the statistics came from Feeding America. So 79% of households report purchasing less healthy food to stretch their food budget. 60% of households are choosing between paying for food or medicine or medical care. And that number is so significant with us in looking at like their barriers and their options. So every day our patients really are challenged, and they're just getting through their day. And this is definitely, you know, sharing in that information. 10% of our patient population has diabetes, 34% of our patients are overweight, 24% of our patients are obese, 28% have high blood pressure, and 34% have high cholesterol. And what we do know is that the clientele for the food insecure population is very similar to the patients that we have, knowing that we're reaching the Medicaid population or the medically underserved population. So it's very similar. With that being said, food insecurity definitely correlates with the health disparities piece, and that's why we were looking for solutions. So if you don't mind going to the next slide, that would be great. When we were looking at the solutions, we decided that, oh, nope, you went backwards. When we were looking at the solutions for what we were going to do, we had just moved into a brand new location, and we are right down and have a downtown central, or Decatur, and we have a ton of urban lots that the houses were torn down years ago. So we are like rebuilding an area in our community that has been desolate for probably 2 or 3 decades. And the community really rallies behind that because we're seeing life again in an area that really needed it. And so we decided to take these urban lots and bring life to them. And it's right over our overpass, so people that are driving through town that are going can see our new location and then what we're doing with all these empty urban lots. But we decided to do a PPRX, which is a prescription produce program with our patients using our gardening. And how we did that was we are collaborating with our soup kitchen that has the Mercy Gardens, and so they have apprentices that they're teaching these skills to, and they are our patient population. In fact, our gardener that we hired from their program is our patient. And they also have, you know, several felons that can't get jobs and different things, so we're supporting their efforts by collaborating with them on a contractual basis for our garden program. We also hooked up with United Way and received 2 years' worth of United Way funding, and that basically is for the infrastructure and for our program and getting it off the ground and running. And so when we chose our patient population for this, we looked at patient qualifiers. And so we didn't use tools for food insecurity, which I think is amazing, and I'm already discussing that with the powers that be here about how we can incorporate more of that, because that's just data driven, and that's really nice along the road to see any change in that for patients that are going through programs like this. So we did segmenting populations. So they had to have diabetes with an A1C of greater than 9, an A1C of greater than 8, with hypertension, whether it was essential or active, with a BMI of greater than 30. And so then once we run those lists of all those patients, we decided we were going to take 5 patients per provider, and then we also looked at a scale of motivation for them on a scale of 1 to 10 in completing the program. The program itself was 12 weeks long. We just finished it up last week. Through our garden and our connection with Central Illinois Food Bank to fill in gaps, we provided roughly 13 to 15 pounds worth of fresh produce to each of these patients every single week. They also got around 47 to 50 recipes that match the food each and every single week, so about 4 recipes a week. And then we had garden to table classes for these patients. So we are going through the data now on how well they did. They met with the dietitian every month, and we did A1C, blood pressure, hip measurements, or waist measurements, thigh and arm circumference measurements with them, as well as surveys throughout the program. And we're kind of going through that data now. So the sustainability piece is we have a market with the food that accepts LINK, which is our food stamps here in Illinois. And we are the first farmers market in our area to accept LINK, and we worked with the state to do bucks back programs. So again, making the healthy choice the easy choice. It just makes sense to incentivize the use of LINK for our patients through fresh fruits and vegetables. We also know that our community is teach, demand to fish type of person, so the education piece of this is so important, and that's why we did classes throughout the program, and then the collaboration is so unique with what we're doing with it. So if you go to the next slide, please. What this provides is what's nice and why we take a look at all of this. And so this kind of goes through the process, and I should have had you kind of going through this, but this is just that the providers help identify the patients. Can you go to the next one? They meet with a dietitian, and we collect all the data on them. They're given a prescription, so they were given 12 weeks of a prescription that they had to give when they came to the market that week. Can you go to the next slide? And that's showing, one of our recipes, and then monthly follow-up, and then end of the season program. And then if you can go to the next slide. So what this was able to do was enable our healthcare providers to be innovative in the care that they were providing. So of course this doesn't take the place of medicine at this point anyway. No, it's an addition. It's the innovation of adding this food prescription. We want to aim to create healthier eaters and decrease chronic disease and facilitate and measure the change. But also what we noticed through this is that in an urban food desert where food insecurity is so high, our patients had a lot more access to fresh fruits and vegetables. And we say they're not going to eat them, but that's not the truth. If it's there, people will eat them, especially if they learn how to use those foods, and they really enjoy them. So I'm really looking forward to the end of data. If you just switch to the next slide. We decided to measure 3 outcomes. Of course, with any of this, you could look at like the food insecurity outcomes, since you guys have such an amazing tool to be able to identify food insecurity through the use of those questions. And then at the end of the program, see if you were able to decrease their food insecurity. That would be a great parameter along with this. But what we were looking at is our objectives were to provide healthy food for our patients that were at risk for obesity-related diseases and their families. And the family piece is important because that's where real change happens over time. And so when you look at funding sources or people who are investing in your programs when they want to know what their return on investment is, that's why healthcare is driven the way it has been all of these years, and that has to stop. So, you know, we look at, we'll wait till you get diabetes, and then we know how much medication costs, and we know how much pretty much you're going to cost us. And so when you look at these individual companies or your payer sources and you're talking with them, you're looking at accountants or people who are driven by numbers, and what they're seeing is they're like, okay, we still have to pay for this person with diabetes. Now you're asking us to pay for all this plus this on top of it when we don't even really know what our return on investment is going to be. But one thing that we do know is that people who eat healthier and are more active have a lower BMI, and therefore their risk for complications is decreased. And so if we can collect this data along the way, then we're able to show the return on the investment. But you're impacting their families too. And so the food that we gave was not just for that patient, it was for the family. We wanted to provide education necessary for patients to increase knowledge and use of healthier foods. Again, that whole visual thing, if I see it and I can see how easy it is, then I'm more likely to try it. And I think that's with any of us. Measure and facilitate change in our current health disparities. If you'll move to our outcomes. And of course I don't have, you know, our true outcomes of the program. You're going to have to go. If you just hit the right arrow, it should go.
Sorry about that. We are hitting the right arrow and it keeps taking us back. So bear with us 1 sec.
Okay.
Hit the left arrow.
Huh.
Nope.
Well, it's not supposed to do that.
Okay, I'm going to keep hitting it and we'll see what, okay, there we go. So it seems to just loop back to the previous one in terms of order instead of just going forward. But let us know if things look off. Again, we'll resume.
Oh, okay, so great. Well, our outcomes initially, what we were looking for is that 100% of the patients that were referred into the PPRX program will receive services, and that did happen. 70% of participants with diabetes will reduce their A1C, and I believe now combing through the data, it's greater than 85% lowered their A1C. And so even with our diabetes self-management education program, and we have a diabetes medical group visit program, and then this program, what we're finding is just, you know, that common link of really pulling people in and getting to know them and providing consistent support and positive encouragement through these programs does lower their A1C. And so I'm really hoping that the average will be greater than a medication on this. And so I don't have all those pieces yet, but 100% of the education classes will have an increased knowledge on how to use fresh produce and a healthful diet. That actually did happen. And 70% of participants will have weight reduction. I don't know the numbers on that. But those were our initial outcomes. For our United Way presentation, they asked for a lot more information that we're collecting as far as like dollars to pounds harvested and all kinds of different stuff that we're looking at, and so for our sustainability piece. Our initial budget for this year, and I kind of know the breakdown because our season is over with, so if you will go to the next slide, because people are probably interested, like how much money did it cost you to pull this off? Was about $15,000. and most of those, like the water tap, our beds that we did because our lead levels were a little bit higher, and we have infestation of groundhogs in our area, so we had to do above ground beds, and our building, land and equipment fees, a lot of that stuff was, you know, infrastructure. Basically, that's all sustainable. That stuff is here now. There's not going to be a secondary cost on it. And so what we need to look at now is how many patients do we want to impact next year, because we're going to grow this. We're going to do an orchard. We're looking at Monsanto helping out with our orchard. And so basically they'll pay for it, they'll put it in, and it takes about 3 years to mature, but that's all sustainable. That's here, it's going to provide fruit every year, not a lot of labor. We're putting in berry bushes now for a bordering, and, you know, again, a fruit thing that comes back every year that doesn't use a lot of labor, that's sustainable. And then we're looking at funding for cyclical years after our 2-year infrastructure build of this, looking at our market to provide at least half of the funding for the labor and the seeds for our patients, and then possibly a CSA with the surrounding community that isn't our patients and our employees through the market. So you can kind of see this is the actual cost of our program this year. And we got 2-year funding from United Way to get this all up and going. The last slide on here just talks, you know, about $15,000 may look like a lot of money, but the cost of healthcare translated is astronomical. And so if you're looking at payer sources, you know, just to do a reminder that healthcare is expensive, and nutrition is a primary low cost-effective way to treat patients. And if you'll turn over to the next slide, this is a picture of our garden. I took it last week. Well, yeah, it's cutting off the pictures, but we've been able to produce a lot from this. We have about 5 more lots to build on over the next 5 years, so we have a 5-year process with it. And you can see kind of we have a little food truck up there that has healthy food all over it, and it's during our market time we have it open with taste tests for the kids and stuff. It's a lot of fun. But you know, screening patients for this project, we looked at segmenting our patients through their health parameters. We did the programming based on our collaborations and the resources that we had in the community, also with gaps in what the community had with this urban food desert and lack of resources to fresh fruits and vegetables. We're doing our data collection on all of the program to look at what our impact was in our patient population, and then we're planning our future for sustainability with this program, as well as growing it too. It's been very, very good for us and our patients. And that is our program and what we're looking at. Do I have any questions from anyone?
Thank you, Allison. That was super informative. So yeah, I want to open it up to questions now from anyone on the phone.
This is Treva from Richmond. I have a question. I think that your presentation is great, first of all, and it sounds really exciting, all the success that you guys seem to be having. So congrats. But I noticed that you mentioned that you're going to partner with Monsanto, and so my question is, we have something going on with local farmers and working within the community, sort of from this you know, the local aquaculture model, and I'm wondering if you guys looked into that, if there were any particular reasons why that wasn't the right path for you.
No, in fact, we have local farmers that are coming in to add to our market next year, so we are collaborating with local farmers. We've had a few local farmers that heard about our prescription produce program this year and donated specifically just for our prescription program, which was fantastic, and we've reached out with them. So just to kind of give you guys an idea of where we are in Central Illinois, so we are kind of the hub of the nation for ADM and Tate and Lyle and Caterpillar. I mean, we're all located here right under Chicago. And so we have the rail hub as far in access to semi-trucks. So we've been kind of marketed as the industry of that central hub, basically. And so we have a lot of interest from key partners in this area, and I know as far as being a dietitian, Monsanto, it has a lot of controversy, and I understand that, but they are interested in doing a platform like this, and they reached out to us when they heard that we were going to look into doing an orchard. And so that's why we're in discussions with them now on what this orchard would look like and then planting it and those types of things. So we've had a lot of interest from different companies in the intermodal industry here in our area, as well as the not-for-profits and farmers. So it's been a huge blessing just to be a little innovative and get the attention of people that normally wouldn't. Did that help?
Allison.
Oh, yeah, absolutely. Yeah, I just was curious. Thank you.
And we have another question from the Reinhardt folks that was submitted via chat. They wanted to know if staff members maintain the garden.
No, there's not a staff member that maintains the garden. That was one thing, you know, being a dietitian and knowing how to cook food, if I had to go out there and maintain this garden, it would be an absolute fail. So, no, we contract with Mercy Gardens, which is that soft skills-based program. It's an urban gardening program under our soup kitchen. And so this program teaches apprentices how to garden, and then they subcontract those people out. So basically they bill us for hours and we pay them and we have a garden. So it's there are patients that are going through this program. Our gardener is one of our patients. And she sees the tie and link into this, and I'm telling you what, that garden is her life. It's her therapy. Her background is not good, and she's an amazing woman, and this has been therapy for her as well. And she is this is her garden as far as she's concerned, and she takes very good care of it.
Thank you. Do we have any more questions for Allison? Allison, I'll ask one, and that is just around, you know, in Oregon here, we are really just starting, I think, to get going with our social determinants-focused work, and it's really exciting to see our larger healthcare system taking an interest there and starting to increase focus and potential resource investment into addressing the social determinants of health. And I'm curious if you can speak to whether, you know, how you sharing this great work that you all have done within your setting, if you're garnering that kind of bigger, higher level attention and potential resource investment to increase work around food insecurity and other social determinants work.
Yeah, so we are, and I can give a few examples of how this is working for us. I put in a grant for a high tunnel garden here so we could extend our season, and the USDA government official called me one day, and he was like, "What the heck are you guys doing?" And I was like, "What do you mean? Am I in trouble here?" And so, you know, the state of healthcare is in crisis mode, you know, if you think about it. And so when he saw what I had written, he said, you know, this doesn't really account for this grant. He said, but you have my attention, and I want to talk to other people in our department, and I want to come out and take a look at what you guys have going on. So he came and visited us, which was pretty amazing, and just really encouraging that model. Then in return, Illinois has not had a state budget in almost 2 years. So I don't know if you guys are aware of that. We're federally qualified just like your system, and so we have federal money, so we're not affected, but our health departments are suffering here because Illinois has not had a state budget in 2 years. There's been nothing passed, no money going out. And so all of our agencies are really having to be different. They're having to think out of the box on how to fund their programs and keep them going. And so for the state of Illinois, for us, it's so clear that where we have gotten our funding for before now, we have to be creative. We have to do things differently. And the head of the health department for the state of Illinois called as well, and he is looking at this whole garden concept and garden to table class concept for educating healthier cooking and healthier food choices, because they see it's a lower cost. See, this is all lower cost. So then on top of that, for Medicaid, we went through, you know, a change in the Medicaid system, and so one of the payers from a different, I think it's Michigan, just Illinois made a contract with them, and Meridian came in and they visited our center last week. It was last week on Wednesday, and they were talking about all of these self-management programs that we have and all of our disease prevention programs like our DPP, and they were in awe of the garden and how that process worked and what patients were getting from it. And so when your quality measures are higher, meaning you put programs in place that provide higher quality, and then the outcomes are higher quality, so patients are doing better and costing less, then they're more likely to pay out. And so that's what we're working on right now.
Thanks, Allison. That's helpful. I want to really quickly, with the last 4 minutes here, I want to now shift us slightly. It looks like we do have OCHIN back on the line, and I know we didn't get time earlier to put questions to Ned and Mary. So with Ned back on, I want to switch gears a little bit and see if there's any questions that you all had for OCHIN around tracking food insecurity within EPIC. And I do have written down, it looks like Linda Larson did have a question about who should be contacted at OCHIN to add food bank info into EPIC. So that's one question, and then I'll open it up and see if there's any others.
Yeah, so I can address that. This is Ned, and we started to address this. I'm not sure how much of the answer that you all heard because our audio kind of cut out. But if you put in a JIRA, have your site specialist put in a JIRA, the help desk, our maintenance team will add food banks or other community resources as a provider type. It gets its own special provider type, and that's something that we can do very, very easily and very quickly. So again, it's just a JIRA to the help desk, and that'll get assigned to the maintenance team just like other provider additions would.
Great, thank you. So I know we don't have the visual up in front of us anymore. Sorry about that, gang. But does anyone else have any questions in relation to the demo and walkthrough that OCHIN did?
Hi, this is Terry at Reinhardt. Can we get slides on the reporting aspect?
Sure. So did you mean the reporting aspect as far as the summary, or as far as the reporting workbench reports?
Yes, the reporting workbench reports. Yes. So we can how we pull that up.
Sure. I think we have some slides on that I can share. Absolutely.
Okay, great. Thank you.
Yeah, well, I'll coordinate with Ned and we can follow up with those.
Hey, this is Brian at Richmond. The last I heard, the social determinant screening had not been moved into a query. I'm wondering if that's something that's in the works, or if there's anything we can do to help push that to happen.
Yeah, so the individual patient, or the patient level questions haven't, the ones that aren't UDS already haven't been moved into Cure. We are working on that. It is on the roadmap, and we're pushing for that. So we have community level, we call the community vital signs, in a Cure, but so far at the patient level, it's just race, ethnicity, homeless status, veteran status, that kind of UDS stuff that's already in there. The rest, we're working on it. I don't have an ETA specifically for you, but we'll certainly keep you posted as we make progress on that.
Great, thanks.
Okay, well with that, we have just now reached 10 o'clock, and I want to be respectful of everyone's time. So I will be sure to share materials out with you all after this webinar ends, and please do feel free to follow up with myself or Victoria here at OPCA if you have any questions for either of our presenters that we didn't get to. I want to thank Allison and Ned and Mary. We really appreciate you guys taking the time to present to us today. And we will be back together on November 11th in a few weeks, at which point we'll be hearing from one of our clinics here in Oregon, One Community Health, on the food program that they've done, and also Lynn Knox at the Oregon Food Bank. So thanks to all, and have a good week. Thank you.
Thanks for having us. Bye.
Thank you.